Hello, I'm Aaron Farberg, and I left my Hawaii background up because, well, we all wish we were there in Hawaii at Winter Clinical Live, even though I'm here with my sweater. I'm a dermatologist and Mohs surgeon at Baylor University Medical Center in Dallas, Texas. Today, I'm speaking on behalf of Castle Biosciences, and we'll be talking about the implementation of gene expression profiling, their DecisionDX melanoma test, in the management of melanoma. My conflicts of interest include research funding, all of which goes to my institution. So AJCC staging is good, and it's come a long way since its inception in the 80s, and it's helpful to us clinicians, but there is room for improvement, and we need to continue to strive to improve what we already know. These charts here illustrate that the vast majority of patients diagnosed with invasive melanoma are stage 1, accounting for 80%, with 92% being diagnosed as having node-negative stage 1 and 2 disease. Now, if we look at melanoma deaths by their initial stage at the time of diagnosis, the vast majority of melanoma deaths are from patients that presented as having node-negative disease, with 1 in 4 patients dying that were initially diagnosed as stage 1. This reveals a very tough reality for us, which is that current staging has low sensitivity at being able to identify the aggressive disease within early stage patients. So an example of this issue is here with staging. If you look at the 5 and 10-year melanoma specific survival for stage 3A disease here, the melanoma specific survival is actually better than for those with stage 2B or 2C disease. Using traditional staging alone can make our ability to refer sentinel lymph node negative high-risk patients for potential life-saving adjuvant therapy quite difficult, or can save lower-risk sentinel lymph node biopsy populations from adjuvant therapy-induced adverse effects. Prognostic accuracy needs to be improved, and it has direct implications on patient follow-up as well. The overlap between stage 2 and stage 3 survival rates can be explained by the limitations of the predictive tools that are currently being utilized in melanoma. Right? The current gold standard in melanoma prognostication is sentinel lymph node biopsy, the procedure. And it's been demonstrated to be an independent prognostic biomarker for patients with cutaneous melanoma. The NCCN Guidelines recommend that the sentinel lymph node biopsy procedure be considered for patients based on an expected risk of being sentinel lymph node positive above 5%. This threshold is actually based on SLNB false negative, an SLNB false negative rate of 5% that was observed in MSLT1 and would include clinical stage 1B, T1B melanomas and above, and T1A lesions with Breslow depth greater than 0.8 millimeters and with other adverse features. Use of this threshold of 5% results in an overall rate of sentinel lymph node positivity of only about 12%, which means the vast majority of patients that undergo this procedure actually do not benefit from it. So the landmark MSLT1 study that I mentioned on the previous slide, it demonstrated the prognostic value of sentinel lymph node biopsy testing, what it offers patients with melanoma. But despite the clear value of sentinel lymph node biopsy, twice as many patients who developed metastatic disease and later died actually had a negative sentinel lymph node. So the NCCN guidelines support that follow-up should be based on the patient's individual risk for recurrence. The NCCN recognizes the importance of a positive sentinel lymph node as a negative prognostic factor and emphasizes high-frequency clinical management that includes increased imaging, clinical surveillance, and consideration of adjuvant therapy. However, there's uncertainty regarding the management of patients with a negative sentinel lymph node. This is reflected in the non-specific guidance that indicates wide intervals for clinical surveillance and imaging. With the rapid improvement in systemic therapies for melanoma, early detection of metastatic disease is truly imperative. There is a need for additional objective factors that can prognosticate the risk of recurrence, which can be utilized within the broad range of recommendations from NCCN to help guide clinical surveillance, imaging, management of patients with cutaneous melanoma. The next few slides may sound a little obvious, but there are sticklers out there, and it's for good reason, but there needs to be a solid chain of evidence for whatever we really do. And it needs to impact our patients in a positive manner. So the data supports the need to identify patients at high risk as early as possible, right? Why? Well, recent studies have consistently demonstrated that earlier detection with lower tumor burden is associated with better response to therapy. Another busy slide here, but the summary is that several contemporary studies have demonstrated that imaging, when part of routine surveillance, is an effective means of identifying distant metastasis and may actually facilitate earlier detection of recurrences, which has been shown to lead to improved survival. Again, this is solidifying the chain of evidence that finding earlier disease is beneficial, and this can be done with surveillance. In the evidence chain is showing treatments, of which we now actually have better treatments, that they can impact disease. All these studies show that earlier identification of metastasis can maximize treatment success. Treatment of patients with lower tumor burden can result in better response rates and improved survival. There's a significant need for additional objective factors that can prognosticate the risk of recurrence to help guide clinical surveillance, imaging, and management of patients with cutaneous melanoma within the broad guidance from the NCCN. Which brings us to the DecisionDX melanoma test. It's a non-invasive, independent prognostic tool validated for the use in patients with stage 1 through stage 3 cutaneous melanoma based on the expression of 31 genes from the primary tumor biopsy. These genes, they comprise of 3 control and 28 genes, all of which are known to be involved in melanoma outcomes. Using RT-PCR technology, it quantifies the expression of each gene against this validated algorithm, which results in classifying patients as either class 1 low risk or class 2 high risk. Class 1 signatures are at low risk of having a positive sentinel node in the T1 to T2 eligible population, as well as low risk for recurrence, and would apply to patients of any tumor thickness. Class 2 patients are biologically high risk and associated with having significantly increased risk of sentinel lymph node positivity, as well as a higher risk of early disease progression, regardless of their T stage. Results are further subdivided into subclasses, with Class 1A being the lowest risk group and Class 2B being the highest risk group. So this is a recent publication in November of this year in JCAD. It was an expert panel of 5 leading dermatologists that all have real-world experience using the 31 GEP. They came together to establish guidance for use of GEP testing for melanoma prognosis within AJCC staging and integration into NCCN Guidelines. The panel met and reviewed published literature on the DecisionDX melanoma test in order to establish and recommend a clinical workflow. I like this slide because it really illustrates a good resume of scientific data that Castle Biosciences has methodically developed over the years with guidance from us clinicians. So the authors of this article found the most compelling aspect of the data was the consistency of the results across every study, whether performed at a single site, multi-center, whether it was sponsored, independent. It was consistent with early data used to support the use of sentinel lymph node biopsy prognostication prior to publication of any prospective trials. And that's what all these Kaplan-Meier graphs really show. The test works, and it works well, and all the data has been consistent. Okay, so this is one of my favorite slides because it really shows how the Castle DecisionDX melanoma test can personalize staging. This is data from a cohort study and demonstrates that the test further informs risk. This is looking at melanoma-specific survival, and if you were to ask where does AJCC8 staging fall here, well, that's what these black dots are. Not bad, right? But look what happens when you layer in the GEP test results. The outcomes are quite different, so much so that they're behaving like an entirely different stage. This is what happens when you have a 2B result. Same thing happens when you get a test result of a class 1A. The melanoma-specific survival goes up as if they were in a different stage again. Again, the test refines and personalizes patients' risk. In patients with thin tumors, a group considered to be low risk but who contribute substantially to mortality, highlighted at the bottom here in red, the expert panel found that the class 2B result was the only factor to reach statistical significance in a multivariate analysis, with a hazard ratio of 9.3 for recurrence-free survival, while the accompanying Kaplan-Meier curve showed a clear significant separation of risk between class 2B patients and the rest of the 31 GEP results. Other data that was reviewed by the experts included a meta-analysis by Dr. Greenhaw published in JCAD of this year. The authors sought to determine the overall effect of the 31 GEP test, as well as its clinical outcome data comparing to AJCC staging in patients obviously with melanoma. Data from 4 independent cohorts were included in the analysis with totaling over 1,400 patients. And here's what they found. The class 2B result was significantly associated with recurrence and distant metastasis. The authors also reported that the 31 GEP identified AJCC stage 1 to 3 patient subsets at high risk for recurrence and distant metastasis, with the sensitivity of 76% for each endpoint of RFS and DMFS. Even better, though, was when the 31 GEP and sentinel lymph node biopsy results were considered together. You can see sensitivity and the negative predictive values were both improved. Yet another systematic review and meta-analysis by Dr. Lichman was considered by the expert panel. This study evaluated all studies on gene expression profiles in primary melanoma prognosis and assessed GEP signatures for prognostic validity and their clinical impact. The authors conducted a meta-analysis on 6 studies on Castle's 31 gene signature. As is the ongoing theme here, the results were all good and consistent. The results of their analysis indicated that high-risk GEP class was associated with poorer RFS, DMFS, and overall survival, as well as sentinel lymph node biopsy positivity. The expert panel also discussed another recent meta-analysis by Marchetti, which discussed the level of evidence for GEP testing. Marchetti found that the 31 GEP to have stage-specific prognostic value with less potential for contributing in a major way to earlier stage disease. This study had several limitations that we listed, and some of which are actually quite concerning to the panel, but overall I think that it was a misinterpretation that omitted important key metrics, including where the Castle test adds value, as well as predicting sentinel lymph node positivity. The panel also evaluated publications that look at the clinical impact of the 31 GEP test. 4 published clinical utility studies have shown that the 31 GEP test impacts clinical management decisions for 1 of every 2 patients tested. Management changes included frequency of clinical visits, use of imaging, lab tests, referrals to specialists, and use of SLNB. The physicians used the test results of the 31 GEP together with AJCC staging within NCCN guidelines to guide risk-appropriate treatment decisions that match the individual patient's biologic risk for their tumor. So in the JCAD expert panel review, the members suggested a clinical workflow for screening and imaging that integrates AJCC staging and the 31GEP test results. The expert panel clinical workflow includes a decision tree to approach incorporating the DecisionDX melanoma tests into your everyday practice. And they have different rationale by staging groups. So seen here for stage 0, the test is not indicated. But for stage 1A, we have data-driven clinicians and, of course, patients. Or there was present of adverse features resulting in uncertain microstaging. Here, a class 1A result can actually reassure patients. This has been incredibly valuable to my patients. A class 1B or 2A result or a class 2B result suggests that the tumor is biologically more aggressive, and that would trigger increased frequency and surveillance and even consideration of sentinel lymph node biopsy. For patients with stage 1B through 2C disease, the GEP test results can inform sentinel lymph node biopsy decision-making and help determine frequency of follow-up, including consideration for clinical trial participation. So focusing on just the two cohorts here, stage 1B and 2C disease, the clinical workflow again provides different rationale for GEP testing by staging groups. If the sentinel lymph node biopsy is not performed, the test can contribute to the SLNB decision, and of course along with T-stage and age, and then it can also help determine how aggressive follow-up should be. A class 1A result in these patients can reassure them and provide a basis for a more informed decision regarding an SLNB surgery. The other class results, including 2B, may inform sentinel lymph node biopsy decision or trigger more aggressive surveillance. Moving down now, so if the patient is already SLNB negative, a class 1A result in these patients offers data-based reassurance. But a class 2B result may trigger increased frequency as well as multidisciplinary follow-up and may even consider adjuvant or clinical trial, adjuvant therapy or clinical trial participation. So the expert panel reviewed, published by Dr. Quatra, considered a recent publication on the use of gene expression profile testing in melanoma from the Melanoma Prevention Working Group. And they identified several limitations resulting in potential sampling error and significant bias as reported from this working group. So the MPWG statement was based on 2 surveys. Only 40% of the melanoma experts surveyed responded to the first survey, with a consensus based on 50% agreement. For the second survey, only 28 participants surveyed actually responded, which is 14%. It's only a 14% response rate, which I believe doesn't actually pass JAMA Derm's published minimum requirement for publication. Interestingly, the majority of the authors had affiliations at academic institutions, with several authors' affiliation all within the same institutions, actually. So this maybe is not representative of the overall clinicians that have experience incorporating a gene expression profile test into their clinical management. The MPWG statement concluded that decisions on performing GEP testing and patient management based on these results should be made in the context of discussion of testing limitations with the patient or within a multidisciplinary group. The expert panel by Quatra agreed, but states that shared decision-making requires the clinician's respect for each patient's individual preference and treatment objectives, which may not necessarily align with the preferences of the clinician or multidisciplinary team as a whole. So to summarize, the expert panel established a clinical workflow for use of GEP testing in melanoma within AJCC staging and integrated into the NCCN guidelines. The panel stressed that shared decision-making requires the clinician's respect for each patient's individual preference and treatment objectives, with the goal of educating patients on treatment options to enable informed decisions. The authors concluded that the DecisionDX melanoma test is a clinically objective metric that can be used in conjunction with traditional clinical pathological staging to help physicians stratify risk in their melanoma patients. The test is useful and actionable for patient care when applied and in accordance with current NCCN guidelines. The test can inform multidisciplinary conference discussions and can assist in determining the intensity of imaging, surveillance, and follow-up care. And of course, patient-specific features of their disease and individual circumstances should also be considered. The expert panel recommends a clinical workflow that integrates the 31 GEP testing under the umbrella of current national guidelines with incorporation of shared decision-making model implemented by a multidisciplinary team and the patient. So this concludes the update and the latest expert information on Castle Biosciences DecisionDX melanoma test for cutaneous melanoma. Thank you again for your attention, and I hope you enjoy the rest of the conference. I look forward to seeing everybody live at a real conference sometime soon. Thank you.